So, good afternoon. Today we discuss about the MRI appearances of early vertebral osteomyelites and discities. The main objective is to evaluate patients with a clinical history of vertebral osteomyelites and discities who underwent MRI very early in their clinical course. Vertebral osteomyelitis with discity is an uncommon but serious bacterial infection. Recently, the incidence has risen markedly, which may be due to immunosuppression in an aging population. When vertebral osteomyelitis is untreated, outcomes are poor. Mortality ranges from 2 to 20%, and there are high rates of morbidity in survivors. Diagnosis is frequently delayed due to the indolent nature of the disease. A high clinical suspicion must be maintained as both blood inflammatory markers and the radiographs are known to be sensitive diagnostic tools. Blood culture results will often raise the suspicion of spinal flux of infection. Staphylococcus aureus is the most common organism. In recent years, MRI has proven itself to be an invaluable tool in the diagnosis of spinal infection. On series showed a sensitivity of almost 100% for detection of infection using MRI. The typical features of spinal infection are contiguous involvement of two vertebrae with inflammatory chains within the intervertebral disc, but these are relatively chronic chains that may take weeks or months to develop. There is a very little in the literature concerning the appearances of very early spinal infection. In this study, it was done a retrospective review of the database of spinal infection performed over a 2-year period. All patients had positive microbiology and a follow-up MRI showing typical features of spinal infection. The MRI findings were bone edema, particularly related to the end plate, abnormal signal within the intervertebral disc, abnormal enhancement of the end plate and the intervertebral disc, and the presence of abscess formation. Approximately 4 cases of hematogenous vertebral osteomyelitis and discity are seen each year at the institution. In 4 cases, the feature typical of spinal infection were not evident at the initial MRI. In 3 cases, there was very subtle edema, end plate edema associated with this degeneration, which was interpreted as modic type 1 degenerative end plate change. The mean time to the repeat examination was 17 days, with a range of 8 to 22 days. The second examinations demonstrated vertebral osteomyelitis and discity. So case 1. A 76-year-old man was admitted with a 4-day history of back pain, fever, and rigors. His general practitioner had prescribed antibiotic presumed urinary tract infection 3 days prior to admission. He had no history of back trauma. He was mildly febrile and tended over the L3-L4 vertebra. The blood culture grew Enterococcus faecalis. Here we have initial MRI images. A, B, and C sagittal, and D axial, A T2, B T1, and C T1 post-gadolinium, and D T1 post-gadolinium. A, we have disc dehydration affecting the L3-L4 intervertebral disc with an adjacent extradural area with high T2 weighted signal that was interpreted as a disc extrusion of high water content. B and C, before and post-gadolinium, there is a small focus of enhancement of the posterior annulus of the L3-L4 and L1-L2 discs. D, axial T1 post-gadolinium, there is ring enhancement around the area of intermediate signal intensity within the anterior aspect of the spinal canal, which was interpreted as extruded disc. So 18 days later, we have A, B, and C sagittal, T2, T1, and T1 post-gadolinium, where we can see vertebral osteomyelitis with discity at L3-L4 with enhancement of the posterior aspects of the end plate and epidural abscess from L1 to L4. A transesophageal echocardiogram showed a mitral valve vegetation. Then, spinal infection was considered secondary to endocarditis. He was treated, and after, he was discharged pain-free mobile and without neurologic deficit. Case 2. A 67-year-old man presented with severe low back pain and leg weakness. He had a history of laminectomy for a prolapsed cervical disc 4 years earlier. On examination, he was septic with fever, peripheral hypoperfusion, and reduced conscious level. He was tender over his L3-L4 vertebra. The blood culture were positive for Staphylococcus aureus despite appropriated antibiotic therapy. His initial MRI images show A, B, and C sagittal, T2, T1, and T1 post-gadolinium, indicating that there are disc prolapses at L2, L3, and L3, L4, and the central canal stenosis. There is a very small amount of end plate edema posteriorly at the L3, L4 level, but no enhancement of the intervertebral disc, and the disc showed chains of degeneration with dehydration, interpreted as modic type 1 degenerative end plate change. A repeat examination was performed 8 days later. A, B, and C sagittal, T2, T1, and T1 post-gadolinium show vertebral osteomielite with discity at L3, L4, affecting the posterior aspect of the end plate, fluid centered on the disc, and an epidural abscess. 2 weeks after, the central canal stenosis was surgically decompressed. Pus drained from the paravertebral abscess grew Staphylococcus aureus. The patient was successfully treated with appropriate antibiotic therapy. Case 3. A 28-year-old woman was admitted with a 4-day history of rapidly increasing low back pain and associated fever. On the 5th day, she had developed weakness in both legs and urinary retention. On examination, she was febrile and tachycardic. Her initial clinical diagnosis was spinal infection, later supported by 2 positive blood cultures with Staphylococcus aureus. So she was started on high-dose intravenous antibiotic therapy. Her initial MRI images show A, B, and C sagittal, T2, T1, and T1 post-gadolinium images, indicating that the L2, L3 intervertebral disc shows disc dehydration. The L1, L2 disc shows a small amount of nucleus pulposus of normal signal. There is very subtle edema and diffuse contrast enhancement of the lower aspect of the L1 vertebral body associated with small node. There is no enhancement within the intervertebral disc. There is a small node in the superior end plate of L2 with fat signal around it, suggesting that this is a long-standing feature. MRI 22 days later, we have A, B, and C sagittal, T2, T1, and T1 post-gadolinium images showing L1, L2, discity, and vertebral osteomyelites. She continued the intravenous antibiotic therapy, having a rapid improvement. Case 4. A 48-year-old man was admitted with a 6-week history of fever, malaise, and weight loss. He had associated diarrhea and vomiting. He was known to have severe aortic regurgitation and was awaiting our aortic valve. On examination, he was febrile and tachycardic, but no peripheral stigmata of endocarditis. 3 blood cultures grew Streptococcus gorgonii. The transthoracic echocardiogram showed vegetation on the aortic valve. He was started antibiotic therapy, appearing to respond well, but 3-4 days into, he complained of pain and reduced range of movement in his right hip and numbness over the right buttock. MRI on day 6 showed A, B, and C sagittal, T2 fat set, T1, and T1 post-gadolinium, showing subtle bone enhancement at L5 S1 with poor definition of the central portion of the S1 end plate. D and E, right parasagittal, T2 fat set D, and T1 post-gadolinium E, showing a focal area of bone edema and end plate enhancement. The appearance was interpreted as focal area of modic type 1 degeneration. 19 days later, we have A, B, and C sagittal, T2, T1, and T1 post-gadolinium, showing that the end plate edema has progressed, and there is now evidence of end plate erosion in anterior cortical vertebral body destruction. Antibiotics were continued, and On day 25, the MRI was repeated. I don't have it to show you this image, but it was showing that the end plate inflammatory had worsened and there was irregularity of the end plates. A diagnosis of vertebral osteomyelitis was made. This patient Discite and vertebral osteomyelitis is assumed to be a secondary embolic phenomenon from his aortic valve endocarditis. So in previous studies, a longer time from first symptoms to MRI causes a delay in diagnosis of 4 months. Spinal infection starts as in osteomyelitis of the end plate and then progresses to the well-recognized feature of Discite. End plate edema is also reported in association with Spinal node. It is important to recognize that this may be the very earliest signs of vertebral osteomyelitis and follow up these changes with a repeated MRI. A progression in the appearance is very suggestive of infection with marked changes occurring from 8 to 22 days, demonstrating convincing progression. So, although MRI is the imaging method of choice for vertebral osteomyelitis in Discite in their early stages, it may show subtle, non-specific end plate subchondral changes. So a repeated examination may be required to show the typical features. So that's all. Thank you.
Hilane, muito bem, parabéns, cara. Aquelas palavras que a gente trabalhou ontem, ficou muito boa.
Aí você pode definir já o tema?
Pois é, eu fiquei atenta agora para poder dar certo. Eu falo em português, explico rapidamente?
Eu acho que sim. Eu acho que...
Estou me ouvindo, será?
É porque está todo mundo com o microfone desligado, pessoal.
Então eu vou falar rapidamente. Se eu devo falar em português, se eu posso começar?
Pode começar.
Então, a intenção do estudo é falar um pouco sobre os sinais precoces que a gente consegue identificar na ressonância de osteomielite e discite. Porque existe uma grande dificuldade nesse diagnóstico precoce na ressonância. É uma infecção bacteriana incomum, grave, e a incidência tem aumentado ao longo do tempo, principalmente devido à imunossupressão e ao envelhecimento da população, tendo uma mortalidade que pode variar até 20% e alta taxa de morbidade também. Então, o diagnóstico tende a ser tardio, mas quanto mais precocemente a gente conseguir identificar os sinais na ressonância, mais a gente vai contribuir. Então, inicialmente, é pela suspeita clínica e pela hemocultura, que a gente vai ter a suspeição de uma infecção na coluna, e o Staphylococcus aureus é o principal associado. E aí a ressonância tem cada vez mais se tornado uma ferramenta útil nesse diagnóstico. O estudo apresentado teve uma sensibilidade de quase 100%, em que as características típicas observadas eram pelo menos 2 vértebras com alterações inflamatórias que a gente tende a crer que tem um aspecto de alterações crônicas, mas, na verdade, levaram semanas ou meses para se desenvolver. Então, o estudo foi uma revisão retrospectiva do banco de dados da instituição, que tinha, de fato, infecção de coluna confirmada, ou pela microbiologia, com microbiologia positiva, e também com a ressonância magnética mostrando achados típicos. E aí foi observado assim, que essa ressonância tendeu a ser repetida em algum momento, com intervalo em torno eu vou até antecipar, né? Em torno de 8 a 22 dias, que é o que a gente mostra aqui. Foram identificados 4 casos que não eram tão evidentes na ressonância inicial, mas que tinham, de fato, infecção da coluna vertebral. Em 3 desses casos, havia um edema da placa terminal, com degeneração do disco, que foi descrito como ODIC tipo 1. E o exame, quando foi repetido, em torno de, na média, 17 dias depois, com um intervalo de 8 a 22 dias, e aí sim veio claramente o achado de osteomielite. Então, foram demonstrados 4 casos, em que a intenção é só mostrar a evolução da imagem inicial e a imagem em seguida. Então, nessa imagem inicial, no caso 1, havia desidratação do disco de L3 e L4 com extrusão, e havia um realce no ânulo fibroso posterior em L3, L4 e L1, L2. Com realce anular, de sinal intermediário no aspecto posterior do canal medular, que foi interpretado como extrusão do disco. Quando foi repetido o exame, 18 dias depois, foi visto que, de fato, havia osteomielite, discite em L3 L4, com realce no aspecto posterior das placas terminais e abscesso peritural de L1 a L4. Quando foi feito o ecocardiograma, e aí viu-se que realmente havia uma vegetação valvar mitral, Daí a infecção da coluna foi considerada secundária à endocardite. No segundo caso, havia prolapso de disco em L2, L3, L3, L4 e estenose do canal, com uma quantidade muito pequena de edema na placa terminal, no nível de L3 e L4, sem realce ao meio de contraste. E havia alterações degenerativas que foram consideradas como modic tipo 1. Quando repetiu o exame, foi identificado que havia osteomielite em L3 e L4, que afetava a face posterior das placas terminais, havia líquido no disco e abscesso peridural. No terceiro caso, na imagem inicial, havia desidratação discal em L2 e L3, havia pequena quantidade de núcleo pulposo com sinal normal em L1 e L2, havia edema no aspecto inferior do corpo vertebral de L1 com o shimol, mas não havia realce de disco intervertebral, e havia também um notimol no platô superior de L2, e no exame de controle, 22 dias depois, havia sim já osteomielite com sinal mais claro. No quarto caso, a imagem foi feita no sexto dia de sintoma, em que se observou que havia o realce de L5-S1, com pouca definição da porção central da placa terminal de S1, e havia uma área focal de edema ósseo com realce da placa terminal, mais numa visão que essa DIE, que é parasagital à direita. Quando foi repetido o exame, 19 dias depois, havia o edema da placa terminal, havia uma progressão do edema da placa terminal, com erosão dessa placa e destruição do corpo vertebral cortical anterior. Então, os sinais já ficavam mais claros. Então, a intenção do estudo, mais uma vez, como a gente já comentou desde o início, é demonstrar que a infecção da coluna ela pode começar com uma osteomielite da placa terminal e pode haver uma progressão aos poucos para realmente reconhecer como uma discite. Atenção à presença do osteomol, que muitas vezes pode ser o primeiro sinal de osteomielite vertebral. Então, é importante estar atento. Nos estágios iniciais, pode ser que hajam achados inespecíficos da placa terminal, e aí a repetição do exame diante de uma suspeita clínica é importante para que haja a confirmação desse diagnóstico. E é isso.